Hi, my name is Adam Mills, and I did my term project on a made-up hospital I called Descension Hospital of Auburn Hills. I was unable to access a hospital due to COVID restrictions, so I had to use my imagination to some degree. But on top of that, I have a number of friends and family who work in hospital systems, and I have had clinical experiences at Beaumont Royal Oak and Ascension Genesis. So a lot of what you'll see in my presentation is based on some of their feedback from their day-to-day. So my safety officer was Jim Johns. He had a master's of healthcare administration. He was responsible for planning and implementing safety policies and the preparation of safety seminars that he did for different floors at different parts of the month. And then two staff where I got most of my information and was able to hang out with was Rob Smith. He holds a doctorate in physical therapy. And then Karen Koss. She was the director of nursing who holds a bachelor's in nursing. And she managed staff nurses on the second floor and did occasional patient care. So the department that I observed was the subacute department, and I'll primarily touch on the topics of back injury prevention, disinfection and infection control, preventing sharp injuries, violence and their policy for combative patients, slips, trips, and falls, and their TB precautions. On the subacute department, they had policies in place for back injury avoidance and patient transfer safety, and it broke down into three things: lift teams, mechanical lifts, and limits of lifting. In lift teams, there was assigned aides that were available to work with the nurses and the therapists, and sometimes all three would work together to transfer a patient. This way it can help distribute the ease of physical burden when transferring heavier patients. And with the mechanical lifts, they had one Hoyer present for the department, and it was capable of lifting patients up to 600 pounds. And all the staff involved with the use of the Hoyer were trained with it, whether it be the aides, the therapists, or the nurses. And on top of that, they had what was called limits of lifting. There was a policy in place that designated how frequent and the volume of weight should be lifted. It said patients that were over 200 pounds requiring moderate assist or greater required two-person lift or a mechanical lift. And the caseload for day-to-day was to not include over 4 patients in that category. So how effective is their patient transfer and back injury policy? So the lift teams in concept worked well, but it wasn't executed all that well, primarily because there was a pretty large lack of personnel to fill these roles. And on top of that subacute floor, a vast majority of their patients were very immobile and very heavy. And this leads to concerns of patient safety, because what you see is whether or not there was available people, there were times where the patient absolutely had to get up and move, and they were done with fewer staff than would be ideal for both the healthcare worker and the patient. And when discussing the mechanical lifts, they weren't really utilized too much, because for one, there was only one on the entire floor, and the rooms themselves were not too accommodating. Due to patient safety, they would often not bring the Hoyer in because there was high potential to unplug machines, IV lines, other things that are crisscrossing across the room. And a lot of times, even if the IVs and the vents were there, the equipment just had a hard time fitting in the narrow room. And the limits of lifting, again, is a good policy in practice, but it was unable to follow, again, because of lack of personnel. There just wasn't enough staff members to help distribute the heavier patients. And it was just unrealistic because you couldn't make the hours work with it. And then on top of that all, even if their policy was practiced in place, it didn't follow NIOSHA's standard. They have a standard of a upper limit of physical lifting for one person, which is 35 pounds. Now to discuss the disinfection and infection control policy. The nurses were responsible for waste removal. This was emptying room trash cans, cleaning minor spills, refilling equipment. This is a large risk for cross-contamination. And it was nice to see that there was sinks and hand sanitizer available in each room, but what you would see is often the paper towels were missing and empty, and same with the hand sanitizer. While they were there, they were often empty and can't be used. And this is just a poor disinfection policy altogether, mostly because of overburdening the nurses. So not only do they do patient care, but now you're making them responsible for refilling room sanitizing equipment, handling waste containers, and this just shows an urgent need for housekeeping staff. When I was there, I even observed cross-contamination moments where you would see handling of medical equipment and handling of trash and not disinfection in between. And this is what is active errors occurring here. You see the nurses making these active errors, and they're mostly built up to make these due to the latent errors of not having appropriate staff to manage these extra responsibilities. I was able to see their policies with preventing sharps, and this was probably one of the stronger suits I saw with this hospital. There was no major safety issues I observed. There was a variety of needles used during patient care, but the vast majority of them were injections delivered via auto injectors where there was just disposal afterwards. You weren't worried about a needle sticking out. And on top of that, there were sharps containers readily available in each room. You could see that they were mostly full, but not quite overflowing. And honestly, the only criticism, they could benefit from emptying them more frequently. Besides that, they seem to have the sharps side under control. I wasn't too sure how to feel about their policy for violence, whether it be from patients or family. At entries of the hospital, they had a well amount of security, and they also had them on some floors, but not on every floor. And you were able to order restraints if there was suspected violent patient interactions, as long as you got a hold with the doctor. And if violence is occurring, their policy is to incorporate as many staff proximal to the event to try and restrain the patient, assuming they have no active weapons on them. And this is concerning both for patient safety and for healthcare workers. This is also not encouraged by NIOSHA's policy standard for violent prevention with nurses. And this is because the general staff might not be trained in how to appropriately restrain someone, and this could result in either the patient getting hurt or staff getting hurt. But I guess the benefit to it would be there is immediate action upon whoever's being violent, which could prevent further violence occurring. The hospital didn't have any concrete written policy about slips, trips, and falls, but you could see there was a high risk of them in the subacute department. There is a high volume of cords, lines, general clutter involved in each patient room, which posed many trip hazards. And to double back on the nurse responsibilities, when you leave the nurses responsible for small spills, they tend to get neglected and not addressed quick enough. And this is a risk for both the patients in the room and any healthcare providers that walk in. And also they had tile floors, which is an increased slip hazard for both patients and healthcare workers. The hospital did have policy regarding TB. For staff, upon hire, they had to be screened for TB symptoms and have a 2-step skin test. And if that was to come back positive, they would follow up with a chest x-ray to rule out any positive results for TB. But when it comes to patients, they didn't have any specific TB policy. However, they did have a policy to put posting on the outside of patient rooms. And this would show you if you need any type of PPE and what type of precautions they had. And they had no engineering controls that were demonstrated in the rooms on the subacute department. There was no UV lighting, no HIPAA filters that I was told of, and there was no negative pressure, and no one even knew what I was talking about when asking about how many changes of room air per hour. So overall, there was a glaring lack of TB precautions and management at the facility level, let alone at the subacute department. There's even vaccines that are available and suggested by OSHA and the World Health Organization standards, but there's little mention of them in the hospital policy, and you could tell there wasn't any major encouragement of them onto their healthcare workers. And despite the overwhelming standards from OSHA for TB guidelines for transmission preventing and guidelines for working with TB in clinical settings, the department appeared to leverage very few or maybe none at all of the engineering and patient care policies outside of universal precautions. There wasn't much policy in place for glove use. What you would see is each room would have 2 boxes of gloves, and they were just for the sizes. There would be a medium and a large, and as the day got busy and gloves ran out, they would only replace the boxes when they needed one more box. So you would only see one size available often. And on top of that, they were primarily latex. Sometimes you could come across a non-latex, but that was sort of haphazardly available. So if you had a patient who had a latex allergy, you were forced to go running around different rooms or trying to find a equipment closet to look for latex-free gloves, which, given how low the staff was and how quick the patient care had to have been, I definitely could see some active errors of giving care to patients with latex gloves when the healthcare provider should have really looked around for non-latex. I feel like the universal precautions was a good policy they had in place. They seemed to do a good job with their PPE and general infection control. Each room you would go to was designated if you needed gowns, gloves, mask, or any other type of protective equipment for either you or the patient. But what you would see is respirators were very scarce, and while the policy was in place, it wasn't practiced. And given our state with COVID, what you saw walking around was inadequate fitting, despite there being plentiful standards and policies for fitting masks and respirators better. And then on top of that, there was inappropriate filtration levels. You didn't see a lot of N95s. You saw a lot of store-bought cloth and some homemade and surgical masks donned. And the last policy to talk about was the department's patient identification, which is the same as the rest of the hospital. The policy in place was built to have redundancies to avoid interventions delivered to the wrong patients. Prior to medication or any type of treatment intervention, the healthcare worker is supposed to ask the full name, the date of birth, and to check the bracelet with a barcode. But what you saw is the policy was only partially followed. Often only name was asked, not date of birth, and often even just the first name. And this increases the risk of delivering treatment to the wrong patient when they're not following the policy this well. And at times, when they would scan the barcode, they would only ask their first name before delivering medication. So to look at the subacute department's strengths and weaknesses, to start with the weaknesses, there is very poor delegation of tasks to nurse. There is inadequate staffing, and it's causing many issues regarding safety. And this is causing all sorts of Latin errors, where you got nurses doing too much and handling too many patients, too many tasks, and it's just inevitable to have an active error with this much responsibility on them. And then some other Latin errors is the lack of appropriate equipment like the masks and the rooms that can't fit lifts. You were hearing lots of nurses having back pain, same with therapists, and it could be alleviated if they managed to make it more friendly with the lifts they had. And the strengths of this place is they had good transparency of infection precautions at each patient room, and SHARP policy was not only a good policy, but they seemed to follow it well. And there's a variety of ideal policies in place, but what you saw is they had a hard time keeping the healthcare workers following them. So to discuss the overall impression of the subacute department, compared to other hospital systems, you could definitely do worse than coming to Dissension of Auburn Hills. Not any hospital is perfect, and they all have their faults. While policies were in place for patient safety, there was frequently issues observed with the staff adhering to them due to excessive work demands on staff. And this could be alleviated if they just managed to find some more staff to fill their roles. If they could try and have more nurses, more housekeeping, you might see a lot of their Latin errors diminish, causing fewer patient safety and healthcare worker injuries or infection. And overall, the healthcare worker's safety seems at a greater risk, more so than the patient safety, given the practices and policies I observed.